All right. Hello, everyone. I imagine more people will trickle in, but let's get started. We are 1 minute past our start time. So welcome everyone to this webinar on gyne imaging. We have three speakers today. I will start with O-RADS MRI. My name is Atul Shinagare. I'm from National Brigham. Then we have Stephanie Nougaret from Montpellier Cancer Institute, who will be talking about advanced ovarian cancer. And then Yulia Lakhman from Memorial Sloan Cancer Center, talking about uterine and cervical cancer. So let's get started. I'm going to share my screen. Stephanie and Yulia, can you see the screen? Perfect. So let's begin. So first part is about O-RADS MRI. I have no relevant conflicts of interest. So we know that adnexal masses are common, but majority of them are benign. And yet, ovarian cancer is the second most common gynecological malignancy, and majority of these women present at an advanced stage. And so it's important to detect this early. And at the same time, many of the masses we detect early are benign. So how do we solve that problem? So the role of imaging is, one, to not miss cancer. In case we happen to see ovarian cancer early on, we don't want to miss that opportunity to detect it early. At the same time, we want to promote appropriate imaging while avoiding unnecessary imaging or surgeries. So that's the balancing act that we need to perform. So the common imaging modalities are CT. Obviously, that's where we frequently see these lesions incidentally. Its role is still evolving. Ultrasound, which is the initial modality for evaluation, and MRI, which has a complementary role, problem-solving role, and it's a little bit more specific compared to ultrasound. So O-RADS is the ovarian and adnexal reporting and data system. It's a multidisciplinary collaboration with radiologists, gynecologists, pathologists, and gyn-onc. It's the standardized lexicon for describing ovarian and adnexal lesions. And it also offers evidence-based risk stratification and management system, especially for ovarian cancer, ovarian lesions. There are currently management recommendations. And those are, hopefully, we'll get some of them for MRI as well. So the goal of O-RAD is to improve the report quality and communication between the radiologists and referrers, to limit the variability in report language, and to hopefully guide the management by optimizing imaging evaluation and avoiding unnecessary surgery. So ultrasound, as I mentioned, is the primary imaging modality, and MRI is the problem-solving tool. So let's start with some basic governing concepts. I'm not going to go into too many details of those. I'll focus really more on the assessment categories, but these first two, I want to make a few specific points. So first is the applicability. We use this for average risk women who have no acute symptoms. It's not applicable to pelvic inflammatory disease, tubo-ovarian abscess, torsion. When it comes to protocol, it's important to have the right protocol because otherwise we will not have the right performance. So that's why we need T2 without fat sat, axial, and either sagittal or coronal. In our practice, we obtain both. Also, the slice thickness is important. When we started doing this, we had to change our slice thickness to match what was the recommended protocol. Then we need something in and out of phase imaging to detect microscopic fat. We need high B-value diffusion weighted images, and then either DCE, which requires temporal resolution of less than 15 seconds for 3 minutes in axial, or you can get non-dynamic T1 post contrast, and that 30 to 40 seconds post injection is the most important sequence for that. So you need one of these two. When we first started, we were just using the regular post contrast images. But over the last few years, we have started doing DCE, and I think that does make a difference. And towards the end, I'll revisit this protocol and why it's important. So lexicon terminology, some few things to remember. There are solid tissues, solid components, solid mass. These terms keep coming up, so let's clarify those. So solid tissue is something enhancing. It can take the form of papillary projections, mural nodules, irregular walls or septations, or solid portion. Other solid components are smooth walls or septations, clot or debris, fat, or Rokitansky nodule. These are solid components. fat qualifies as a solid component, but it's not the same as solid tissue. Because solid tissue here, we are thinking something high risk. Other solid components are low risk. And then when we say solid lesion, it has at least 80% solid tissue. That's a solid lesion. And then enhancement patterns, if you're using DCE, either we have low risk curve, which has minimal gradual enhancement, there's no shoulder or plateau. There is intermediate risk curve, that's O-RADS 4, where there's moderate upslope, but it's less than the myometrium, and then there is a plateau. And then there is high risk curve, which is marked upslope more than myometrium. The slope is more than myometrium, and then there's a plateau. So these are the types of curves that differentiate between O-RADS 3, 4, and 5. And then enhancement pattern is non-dynamic enhanced, that is 30 to 40 second post-injection. If it's equal to less than myometrium, that's O-RADS 4. Or if it's more than myometrium, it's O-RADS 5. That means we cannot assign O-RADS 3 if we don't have DCE. All right, so now let's talk about the meat of this talk, assessment categories. Now, first thing to remember, the risk of lesions, that's PP, positive predictive value, is different from O-RADS ultrasound. Because MRI is supposed to be more specific, that's why these numbers are higher for O-RADS 4 and 5. So first is normal ovary. If there's no lesion, follicles, corpus luteum, that's O-RADS 1. If there's a lesion with lipid content, that's usually non-enhancing solid tissue, no enhancing solid tissue, there may be Rockett's nodule, that's O-RADS 2. But if there's a lesion with lipid content with a lot of solid enhancing tissue, like here, that's O-RADS 4 because that can be a malignancy. Then dilated fallopian tube, if there's no enhancing solid tissue, if it has thin walls, simple fluids, that's O-RADS 2. But if it has thick walls or non-simple fluids, for example, pyosalpinx, hematosalpinx, that would qualify as O-RADS 3. And then if there's peritoneal disease, that's O-RADS 5. I'm going to revisit these categories a little bit later, but I just want to focus on these lesions, sort of big buckets of lesions. So something with lipid, dilated fallopian tube, anytime there's peritoneal disease. Now, simple ascites does not qualify as peritoneal disease. It has to be peritoneal nodules or nodularity or thickening. Then unilocular cysts, no wall enhancement, simple or endometriotic fluid is O-RADS 2. But if there is wall enhancement or hemorrhagic or proteinaceous content, that's O-RADS 3. Now we go into a little bit higher complexity, multilocular cyst. That's O-RADS 3. So something to keep in mind, one, size of the lesion doesn't matter. If it's a cystic lesion, O-RADS 3 is as high as it would go on MRI. Now, if there is solid tissue, if it's dark on diffusion and dark on T2-weighted images, like this, that's O-RADS 2 because that's a fibroma, fibrothecoma. Now, if there's solid tissue that's not T2 dark, then you look at time intensity curve or enhancement. If there's low time intensity, low risk curve, like this, almost flat line, gradual enhancement, that's low risk. If it's a little bit higher but less than myometrium, that's intermediate risk. And if it is quick upslope, that's high risk. Or you can use comparison with myometrium to assign O-RADS 4 or 5. All right, so now let's look at a few more examples. So O-RADS 2 includes lesions like unilocular simple cyst, endometriotic or endometriomas, simple dermoid cysts, fibromas, hydrosalpinx with simple fluid, paraovarian cyst. All these are O-RADS 2. O-RADS 3 is unilocular lesion with hemorrhagic content or proteinaceous content or multilocular cyst with no enhancing solid tissue. Or it could have low risk curve, lesions with low risk curve. Or like I mentioned earlier, pyosalpinx or hematosalpinx. These are O-RADS 3 lesions, slightly higher risk, about 5% risk, but still mostly benign. Now, intermediate risk is, like I mentioned here, solid tissue with enhancement equal to or less than myometrium. You can just put regions of interest and see what the enhancement looks like. Or lipid content with large amount of enhancing solid tissue, because that could also be malignancy. Or something like this, where there's a lot of solid tissue, but again, enhancement, even visually, that's myometrium, that's the lesion, enhancement less than myometrium, Or if you have risk curves, it's intermediate risk curve, which is upslope but less than myometrium. And then high-risk lesion is something like this, where enhancement is directly more than myometrium, just putting regions of interest, or lesion with peritoneal nodularity, or something like, oh, here again, another example of peritoneal nodularity. So there's solid lesion with peritoneal nodularity, or here we have bilateral masses, and on both sides, the upslope is greater than myometrium. So these are all examples of O-RADS 5. So now, in the next few minutes, let's quickly visit algorithm and a couple other points. So on the O-RADS website, there are many helpful resources. So if you're just beginning to start using this, this is very useful, very helpful to look at these. So again, we have normal ovary, lipid content, dilated fallopian tube, peritoneal disease. And then this middle big bucket with a lot of other adnexal lesions. To keep it simple, if they're cystic lesions, these are O-RADS 2 to 3, depending on whether it's uni or multilocular, wall enhancement, and type of fluid. And for solid lesions, first thing you look for is it T2 and diffusion dark? And if not, you look for the enhancement type to decide between O-RADS 3, 4, and 5. So if you want to create a simplified algorithm, if it's normal ovary, it's O-RADS 1, peritoneal disease, O-RADS 5, lipid content, O-RADS 2 or 4, solid tissue, then is it like, if there's no solid tissue, if it's uni or multilocular cyst, it's O-RADS 2 or 3. If there is solid tissue, whether it's dark, fibroma, O-RADS 2, other lesions, O-RADS 3 to 5. And if there is a dilated fallopian tube, it's O-RADS 2 or 3. So if you really want to simplify into bigger steps, is it look for just physiologic lesions, then look for peritoneal disease, then look for lipid content, look for solid tissue, dark or not. And then if not, there's look for enhancement. So these are the major steps that you go through, because if you see peritoneal disease, you're pretty much done. If you see lipid-containing tumor, it's O-RADS 2 or 4, you're done. But then you go into this stepwise progression. Few resources, there's O-RADS MRI calculator. It sort of walks you through the questions, very easy to use, super helpful. It sort of goes through these various questions. There are guides about how to report templates, and there's O-RADS MRI primer on ACR website. So couple quick points. Why do you need this DCE and in phase and out of phase? So let's start with this lesion. Cystic lesion, enhancing solid tissue, little bit of enhancement here, restricts diffusion. So if you were to assign without DCE, it would be O-RADS 4. You'll assign 50% risk of cancer. But hey, you know what? We had actually DCE that assigned a low risk curve. That means the risk dropped in our report to 5%. But hey, we also had in and out of phase that showed some microscopic fat. That means this is a fat-containing lesion. There's no large amount of solid enhancing component. Really, this was O-RADS 2 lesion, 0.5% risk. So just by using the right sequences, our risk reported in the report, like that went from 50%, which would lead to surgery, to 0.5%, almost certainly benign, avoid surgery. That's why it's important to have all the correct sequences. And MRI and ultrasound have complementary role. They both have excellent performance. MRI serves as a problem-solving tool. For example, here, O-RADS 4, on ultrasound, it was O-RADS 4. We had this lesion, multilocular cyst, no solid component, but irregular internal outline. But when we got the MRI, we just saw some multilocular cyst, no solid component. So we were able to reduce the risk to less than 5%. So in conclusion, O-RADS is a standardized lexicon and risk stratification system. Ultrasound and MRI are the two primary modalities. I mean, ultrasound is the primary modality, MRI problem-solving role. We have many resources on the ACR website. Peritoneal nodules or irregular thickening is O-RADS 5. Lipid content, O-RADS 2 or 4. Lesions without solid component, O-RADS 3 or less. If there is solid tissue with T2 and DW at dark is O-RADS 2. Otherwise, you look for enhancement, O-RADS 3 to 5. Thank you. So now let's move on to our next talk. We will continue to monitor questions in the chat, and then we'll circle back to all the questions at the end of our session. So Stephanie, on to you.
Yeah. Do you see my screen?
Yes.
Good. So now we move to the advanced stage when ovarian cancer has like spread to the peritoneal cavity. So how we can help the surgeon? So basically for ovarian cancer, we have two management paradigms. First is like primary debulking, which is usually the upfront surgery when the tumor and the metastases are being all removed at upfront surgery. And then we have the second part where the tumor is already too advanced and the patient gets an NICT, then interval debulking at the end. So basically, there is multiple studies, but there is always a war between like upfront surgery or neoadjuvant treatment. It depends mainly on like the skills of the team, continent. There is like plenty really of variation, but at the end, it's the surgeon who will choose whether he go for upfront surgery or for neoadjuvant treatment. And this is the role of you as radiologist to help the surgeon decide whether to put the patient on upfront surgery or on NICT. So I like to describe peritoneal carcinomatosis in ovarian cancer as an iceberg. We see the tip of the iceberg as a radiologist, but usually what is still on surgery is way more advanced. So what are the different imaging modalities and their strengths and limitations? I will focus mainly on CT and MRI. PET is more usually used for recurrence. So the CT has usually a high accuracy for detecting peritoneal carcinomatosis with an AUC of around 0.9. However, it really depends on the lesion location and the size of the lesion. When you look into detail, for example, it's very good for detecting omental caking or lesion in the omentum. But if we are looking for a smaller lesion, like a lesion less than 1 centimeter, or lesion within the mesenteric or in the serosa, well, we are very, very poor in this assessment. So just as a few cases to correlate, here, as you can see, there is a large implant here, but when you look on the perioperative assessment, there is clearly a very advanced, more diffuse lesion. In this case, for example, there is just a fat stranding, but in this case, as you can see on perioperatives, there is a large infiltration. So for the MRI, the conventional MRI, as with including T1, T2, and contrast images, are probably the same accuracy as CT. What's really improved the accuracy is the adjunct of MRI, and I should say pretty recently. The last guidelines and the joint guideline between ESGAR, ESGO, PSOGI, and EANM has shown that MRI should be the gold standard for imaging the peritoneal metastasis of ovarian and colorectal cancer prior to surgery. So just as a few images to compare between CT and MRI, really in the pelvis, I would say like you switch on the light and you do see very nice resolution of the relationship with the tumor, the implant, and the organs. The MRI really improve, I would say, the detection of implants, especially on the perihepatic implant. And as you can see, you had the diffusion. It really light up everything. Same in the pelvis. So how we can help the radiologist, the surgeon as radiologist? So in three parts. First part is to detect easily the extraperitoneal metastasis, especially on CT. And then we will assess the PCI, I will explain later. And then to get them a sense of the potential resecability of the tumor. So extraperitoneal metastasis, it's easy. You look for lung disease, you look for liver disease. The diagnosis is super rare for ovarian cancer to have already spread to lung or liver. Usually it's spread on the peritoneum. So what is a PCI? There is different classification to assess on the surgery. The criteria for resecability, we have Fagotti score, we have Sweden score, and we have the PCI. This is what we use in Europe. So it's a peritoneal carcinomatosis index. And basically, it was invented by a colorectal surgeon from Boston. And basically, it divides the abdomen in 13 quadrants. So 9 quadrants are like a tic-tac-toe, and then you add 4 quadrants for the small ball. And then you can assess the size of each implant in each quadrant and give a score. And as you can really understand easily, the larger the score will be, the worse would be either the difficulty for resection and the prognosis. So we do use PCI, especially to assess on CT and MRI, to give a sense to the surgeon of the volume of the disease and the tumor burden. So this is what we did, and we have, like, just to highlight with Yulia and Atul, done and how do we do it in radiology. It should be published very soon, and it's, I would say, summarize what I'm giving in this talk. So basically, how I read peritoneal MRI, I use this wagon wheel drawing. So basically, I take the first wheel has the omentum, the liver, and the spleen serosa. The second wheel is the small bowel and the large bowel. The spoke of the wheel has the mesentery, and then the center is the root of the mesentery. And you can easily understand that the closer to the root, the harder it will be to resect. And then I use, when I'm reading some clockwise rotation, because the peritoneal fluid is doing like the clockwise rotation. So I start by the bottom and then go up, like for example in the coronal format, and go down again. And I do circle from the periphery to the center to pick up all the implants. So let's say what is like easy to remove and what is not easy to remove. So first, when we open a case on CT or an MRI, what we usually see is the omentum and the omental clicking. Well, this is the first thing I actually saw on the operative setting, and this is the first thing they remove. So there is absolutely, for the surgeon, no difficulty to remove the omental clicking. So there is no, it's not worth it to describe this omental caking, because they don't really care about it. They care what is behind the omental caking. So we don't care about the omental infiltration. As I show you here, it's a drape. They cut it and that's removed, and then they have access to the rest of the cavity, especially the small and the large bore. So just as an example of this sausage-like omental caking on MRI. So what is really important for the serosal and the first wheel is more like the liver infiltration, because it may need the an extra like skill for the surgeon to have a hepatobiliary surgeon coming. And what's the second point is to not mistaken it with liver metastasis. We do see at the tumor board every patient coming. They say it's like a stage 4 disease because there is liver metastasis, and it's never liver metastasis. It's always peritoneal implant. Why is that? Because at the diagnosis, liver metastasis is very rare in the ovaries. So I would always follow, especially if it's very peripheral, serosal metastasis instead of a liver parenchymal metastasis. So that's the first point to know. And then we focus on what is really important. I love mnemonics, so I call it the bumpy word. So bowel, upper abdomen, mesentery for peritoneal carcinoma. So this is really the three things you really need to scrutinize when you are assessing your peritoneal carcinomatosis to tell the surgeon whether it's invaded or not. So bowel, it's easy. You will follow the large bowel and the small bowel to see if there is already some involvement. And usually when you have between 3 to 5 segments which are involved, that's preclude upfront surgery, because they will need to cut all those segments and increase the morbidity. Then we've moved to the upper abdomen, and all this area is really important. And usually we don't really spend time on the CT or MRI to look at this area. So what we are looking at is the diaphragm, the porta hepatis, and all the area surrounding the stomach. So first, the diaphragm. I love looking at the coronal format, especially when you have ascites. You do see very nicely the implants. So it's usually not a contraindication, but you need to tell them because they need to do striping of the diaphragm. So just as a correlation with MRI, with some nodule here on MRI, it was very nicely depicted because it was very thin with the diffusion. Then the porta hepatis. So if it's the disease is here, it's not a problem. But if it's really upper and deeper within the bifurcation, that's a problem. So that's really critical to tell them, because that's preclude resecability upfront with surgery. Just as an example here, that was something in the falciform ligament, so that was resecable. And as you can see, before and after, they remove it. Then we have all the surrounding stomach. So, we have some cutoff of like 2 centimeters within the gastrohepatic ligament, the lesser sac, where it's at. Because if you start to remove all those parts, you have to clip the vessel, and this will completely block the drainage of the venous drainage of the stomach and lead to a gastric infarct. So that's really important to look whether there is an extension within surrounding the stomach, especially in the gastrohepatic ligament and lesser sac. So as some example here, you do have some large infiltration, especially as you can see here, already the serosa of the stomach is involved. So that's preclude surgery. And then at the end, and it's usually the worst part, is a mesentery, and it's very difficult to evaluate the infiltration within the mesentery. But with a few tips, you can improve your accuracy. So what we are looking for mesentery infiltration, we are looking to 3 patterns: the nodular pattern, the infiltrative pattern, and the retractive pattern. So nodular pattern is easy. You are looking for the nodule within the mesentery. The second pattern is a misty mesentery. So what you are looking, it's a very subtle sign where you have like this linear serpiginous aspect, which I call it the wet mesentery. So it looks like wet, and it's then in contrast with this aspect with like really dry mesentery. You can do see it on MRI before and after. Like here, here you do see like it's very wet on this MRI, and here it's like dry, but you do have ascites. And that's something difficult when you have ascites. It's very difficult to know whether it's like just the infiltration because of the ascites of really infiltration. But what's helped is that it's like very serpiginous, linear, and you feel like it's completely frozen. So I will call it and favor more an mesentery infiltration. And then I would say the most easy but less described pattern is the retractive pattern. Look at how are the bowel loop ordered into the abdomen. If you do see that they are like, there is some kinking, some angulation, some bowel rotation, you may think that this is an infiltration, and usually it's massive infiltration. So at the end, you will be able to tell the surgeon what is really resecable or not. And just to finish with the last minute I have is like we moved. So now, so I told you like all the tips for resecability, but we have moved to a more standardized like section and structured report approach. It's really essential because at least you won't miss the mesentery or the gastrohepatic ligament approach. So that's why we really try to structure and to provide synoptic report for ovarian cancer. And just as an example, and this is on the paper we just published, so we provide some example of infiltration and to have the synoptic report. It's very helpful for the surgeon because they know exactly what is invaded and what is not, and they know whether this patient can be operated or not. And as you can see here, in this patient, there was huge infiltration of the mesentery, and that's preclude upfront surgery. This patient again, so we did the same on MRI with the same synoptic report. As you can see here, there is like a periportal infiltration through the bifurcation. Again, as I told you, that's for sure preclude upfront surgery. And if you can see all the disease on the diffusion as well, you can know that this patient will go for an ECT first. And in this case, it was a more limited disease, and this patient was able to have upfront surgery. So just in conclusion, at the moment, we are not perfect for assessment of the peritoneal lesion and the resecability. However, with the help of really structured report and the few key points I gave you about the infiltration of the bump pattern and the bowel, the abdomen, and the mesentery, we are like really improving our evaluation and improving our patient management with this close collaboration with the surgeon. So with that, I would like to thank you, and we wait for the question for later, I guess. Thank you, Atul.
Thanks, Stephanie. That was fantastic. All right, Yulia, on to you. Thank you.
So I'm going to focus on cervical cancer and specifically the role of MRI in initial evaluation of patients with cervical cancer, just because we have limited time, and I wanted to cover at least one topic in a little bit more detail. So we'll discuss the epidemiology and staging system, the tailored MRI protocol, the key MRI findings to report, and we'll talk a little bit about the follow-up strategy. Cervical cancer is the fourth most common cancer in women worldwide. It affects women of reproductive age. The main causes are chronic infection with HPV. Concurrent infection with HIV also increases the risk approximately sixfold. The good news is that cervical cancer can be detected early with HPV DNA test, and it can be prevented with vaccination against HPV. The most common histologic subtypes are squamous cell carcinoma, followed by adenocarcinoma. Cervical cancer is staged using the FIGO staging system. It was last revised in 2018. And the important update was that pathologic and imaging findings can be used to assign the stage, with pathologic findings taking precedence over imaging. Other important updates was that for the disease confined to the cervix and visible with the naked eye, it was now divided into 3 groups instead of 2, based on the maximum tumor dimension. This recognizes the fact that patients with tumors 2 centimeters or less have better oncologic outcomes and may be eligible for fertility preservation if desired. There's no change to stage 2 disease, with stage 2B again being parametrial invasion, very important. There is an update to stage 3 disease in that there is new category stage 3C, which indicates the presence of pelvic and or para-aortic lymph nodes. This is very important because the presence and the number of metastatic lymph nodes is the most important prognostic factor in cervical cancer. There's no change in stage 4 disease, but it is important to note that to diagnose invasion of the urinary bladder or the rectum, it is important to see the tumor, or we must see the tumor in the mucosa or the lumen. The bullous edema by itself is insufficient to diagnose stage 4A because it's a nonspecific finding and can be seen with infection or inflammation. Patients are typically asked to fast. We administer an antiperistaltic agent to reduce motion. Also, at our institution, we give rectal enema or suppository to reduce rectal gas. We ask patients to avoid to optimize the uterus positioning in the pelvis, and vaginal gel is optional but used at many institutions to better delineate tumor extent, including involvement of the vagina. Patients are typically imaged supine. It can be done with 1.5 or 3T. 3T has higher signal-to-noise ratio and allows for higher spatial resolution. But if there is metal, then 1.5T is preferred to reduce the susceptibility artifacts. All GYN MRI share common protocol elements. This includes localizers, and if possible, we recommend performing either axial or coronal T2-weighted images through the retroperitoneum to evaluate for para-aortic lymph node metastases. And then the dedicated images through the pelvis include T1, T2, and diffusion-weighted images. In case of cervical cancer staging, contrast-enhanced imaging is optional and is primarily used for research purposes. So for cervical cancer staging, the key sequences are T2-weighted images, typically performed in sagittal and oblique planes, because they are really the best for assessing the anatomy and for delineating tumor extent. The axial oblique images are planned using the sagittal plane, and they're prescribed perpendicular to the cervix. The axial oblique T2 and diffusion-weighted images are very much complementary to each other. They're performed with the same field of view and slice thickness to allow side-by-side comparison. In order to be good at interpreting images, it's really important to know the anatomy. Just very briefly, The uterus is divided into the uterine corpus and the cervix. The outer myometrium has intermediate T2. It continues down as the outer cervical stroma. The inner myometrium is low T2 signal. It continues down into the cervix as the inner cervical stroma. In the center is the high T2 signal endometrium, which continues down as the endocervical canal. The uppermost extent of the endocervical canal is internal os, and the inferiormost extent is the external os. The junction between the uterine corpus and the cervix is called the isthmus. And the isthmus and the internal os are located at the same spot. So when you take the short axis view through the cervix, then in the center is endocervical canal, followed by cervical stroma, and the connective tissues on both sides are the parametria. And the location of the isthmus, so the internal os, is important for patients being considered for fertility preservation, and it's indicated on the sagittal view as the funneling or narrowing of the endocervical canal before it widens as the endometrial cavity, or even more reliably on the short axis view through the internal os, it's indicated by the entrance of the uterine vessels. And then the horizontal line drawn at the level of the bladder neck divides the vagina into the upper and lower 2/3. Upper 2/3 and the lower 1/3, which is important for staging. So T2 and diffusion are really best for evaluating local disease extent. And the question we want to ask ourselves is whether the tumor is confined to the cervix or upper vagina, and if so, the size is important, or has it spread beyond? If the tumor is confined to the cervix and upper vagina and it measures 4 centimeters or less, the treatment of choice is surgery with a subset of patients who may be eligible for fertility preservation. If, on the other hand, the tumor is more than 4 centimeters or it has extended beyond the cervix and upper vagina, then the treatment of choice is chemoradiotherapy. And typically that's delivered as concurrent chemo-RT followed by brachytherapy. Unfortunately, MRI has only low to moderate sensitivity for detecting lymph node metastases because we primarily rely on size criteria for diagnosis. The ancillary features can help, but are not reliably seen. And diffusion-weighted images increases the conspicuity of both benign and malignant lymph nodes, but cannot reliably distinguish the two because the ADC values of the two overlap. So PET-CT, FDG PET-CT complements MRI for evaluation of local, regional, and distant metastases, and is primarily indicated in patients with either bulky disease or with tumor spread beyond the cervix and upper vagina. It allows to evaluate for pelvic and parotid lymph nodes and tailor radiotherapy. And if there's distant metastases, then the best treatment approach is palliative chemotherapy. If the patient is eligible for surgery, then they can undergo traditional surgery, which consists of removing of the uterine corpus and the cervix, as well as the parametria, which are the connective tissues surrounding the cervix, and the upper vagina. In a small subset of carefully selected patients, fertility-sparing surgery might be possible, and we'll discuss the eligibility criteria for that. So the eligibility criteria for fertility-preserving surgery is basically desire for fertility preservation. There are 2 must-have criteria. So the patients must have either squamous cell carcinoma or typical adenocarcinoma, and this disease must be confined to the cervix. And then there are several ideal to have criteria. So it's ideal that the patients have small tumors, 2 centimeters or less. It's ideal that the distance between superior extent of the tumor and the internal os or isthmus is 1 centimeter or more. And it's ideal that there's only superficial involvement of the cervical stroma. However, there's some flexibility about these ideal to have criteria. So when there is surgical treatment of cervical cancer, really the first step is lymph node evaluation because the imaging kind of falls short. And there's been a major paradigm shift in that sentinel lymph node mapping is now the primary approach to evaluate the lymph nodes. It consists of injecting the cervix prior to the surgery with a dye and then removing the first draining lymph nodes or the sentinel lymph nodes. So I hope I kind of build up the stage for you to understand that the parametrial invasion really defines management. And the best way, because basically if there's parametrial invasion and the tumor spread even beyond the parametria, then the treatment of choice is concurrent chemoradiotherapy. So oblique plane of T2 in diffusion is really the best way to evaluate for parametrial invasion. The tumor typically starts in the center in the endocervical canal and spreads outwards. They can be partial, full, or full thickness cervical stromal invasion. So if there's a partial cervical stromal invasion, you see this intact low T2 signal intensity rim of the cervical stroma that helps to definitively exclude parametrial invasion. Sometimes they can be full thickness cervical stromal invasion, but by itself, it's not enough to diagnose parametrial invasion as long as there is a smooth interface between the tumor and the parametrium. To reliably diagnose parametrial invasion and hence the need for concurrent chemo-RT, we want to see the nodular interface between the tumor and the parametrium as illustrated on these images. Or we want to see a spiculated interface between the tumor and the parametrium. The addition of diffusion images to T2 improves both the sensitivity and the specificity because it allows to better delineate the tumor margins. And it also allows to more reliably distinguish tumor from fibrosis or edema. Large tumors can cause venous congestion, and prior procedures can cause fibrosis, and both of them can have intermediate signal on T2 weighted images. So when you see the full thickness cervical stromal invasion, as on these T2 weighted images, we want to again look for the outer contour and confirm that it's smooth, especially focusing on diffusion weighted images. Because again, they help to distinguish tumor from fibrosis and edema that can look similar on T2. So just an example of a 37-year-old woman with squamous cell carcinoma of the cervix. And this patient has a relatively small tumor of approximately 2 centimeters. And there's full thickness cervical stromal invasion. Perhaps on T2 weighted images, one can question whether there is a nodular outer contour. But if we focus on diffusion weighted images, which again improve the delineation of tumor margins, we can see that in fact there is nodular interface between the tumor and the parametrium. And the best treatment for this patient is concurrent chemoradiotherapy. Again, I want to emphasize that for patients to diagnose with bladder involvement, it is critical to see tumor extension into the mucosa or the lumen to diagnose bladder invasion or stage 4A disease. Abutment of the bladder wall or involvement of the muscle wall without the involvement of the mucosa or the lumen is not sufficient to diagnose stage 4A disease. And the presence of bullous edema, as you could see on some of these images here, by itself alone is insufficient to diagnose stage 4A disease because it can be from infection or inflammation. And another point I want to make is that when suggesting involvement of the vagina, it's not enough to just see tumor protruding into the vagina. We really want to see tumor invading the low T2 signal intensity wall of the vagina. Okay, so follow-up, where to look for recurrence. Typically, most recurrences 2 to 3 years, within 2 to 3 years of treatment. The follow-up really depends on the primary treatment that was received. The most common sites are vaginal cuff after the surgery, the site of the regional tumor in the uterine cervix after chemoradiotherapy, and lymph node metastases in regardless of the type of treatment. So typically the patients who undergo surgery are imaged only if there's concerning symptoms or findings on the clinical exam. Patients who are treated with fertility-sparing treatment, the imaging is usually with MRI at 6 months and at a year, and then as needed. But it's very important to follow up patients who receive chemoradiotherapy. They usually undergo staging FDG PET and MRI prior to treatment to evaluate accurately disease extent. Usually MRI is performed after the concurrent chemoradiotherapy and before the chemo and brachytherapy boost in order to evaluate how much the tumor shrunk and also to plan brachytherapy. And these patients also should be imaged at 3 months and preferably at 6 months after the completion of all chemoradiotherapy. MRI can be added at that time. Why is it important to image these patients at 3 to 6 months? Is because the findings on the PET scan are very prognostically relevant. So patients who have a resolution of the FDG avidity at the site of the primary tumor and resolution of all sites of FDG avidity have excellent prognosis. Whereas if there is a residual FDG avidity or there's increased or new foci of FDG avidity, then these patients do poorly and they perhaps require or often require salvage surgery. Now, at 3 months after the chemo-RT, we may see inflammation. So typically, it's best to perform the FDG PET at 6 months to be sure if there is residual tumor or not. On MRI, it takes a long time for the tumor to regress and the inflammation to go away. It takes about 6 months, and the reliable feature indicating tumor-free cervix is reconstitution of the low T2 signal intensity cervical stroma. Unfortunately, some patients do recur, and the recurrent tumor basically looks very similar to the primary tumors. And then there's FDG avidity, there's intermediate T2 and restricted diffusion, and these patients require salvage surgery for treatment. So in summary, use a tailored MRI. It will help you to accurately stage patients, report key findings to help the clinicians. This include maximum tumor size, involvement of the parametria, lymph node metastasis, involvement of the lower 1/3 of the vagina, involvement of the bladder rectum, and consider using a structured report to make sure that everything is addressed in the concise, clear, and organized fashion. And with that, I thank you for your attention.
Thanks, Yulia. That was excellent. So we have a few more minutes for questions. I see a few popped up in the chat here. People can continue to type more questions if they think of more, but we can start here at the top. So what if the lipid content, assuming the adnexal lesion with small enhancing soft tissue? So most of the times that would be Rokitansky nodule. So lipid containing lesion would be O-RADS 2. And it's okay if there's a small enhancing soft tissue, that would be the Rokitansky nodule. That wouldn't change anything. If you do see a large solid tissue, and that we don't have really good set number on how large is too large of solid tissue, but if you subjectively feel there's a large amount of solid tissue, then you assign it to O-RADS 4, but it would not become O-RADS 3. Then there's some comments about screen share. Okay, so how to differentiate portal edema from deposits at porta hepatis, Stephanie?
That's a very good question. Usually when you have like portal edema, it's more diffuse and it's like a lower signal and lower density on CT. And it's more like lobulated and it looks like tissular on CT for metastasis. On MRI, it's easier because it will like a T2 hypersignal T2 for the edema, and the rest will be intermediate signal for the infiltration of the tissue. I must say I don't have that problem of portal edema, because usually you don't really see portal edema for patients who never get surgery initially for baseline and after an ACT. Usually you can say that it's easily like tisular disease and metastasis. It's more indeed when on post-operative setting, you may see that there is some portal edema, and then it's more complex to know whether it's like still residual tumor or like portal edema, but I would look at the density.
There's one question in the chat here. This for you, Yulia. Do you give the measurements from internal loss of cervical tumor in the report for potential fertility-preserving surgery?
Sorry, can you repeat this? It's a little muffled.
Oh, sorry. Do you give the measurement from the internal os of cervical tumor in the report for potential fertility-preserving surgery?
Oh, right. So yes, absolutely. That's a critical measurement. The ideal distance between the internal cervical os and the superior aspect of the tumor is 1 centimeter or more. And that's very important to include this in the report. Like I said, it's ideal, but sometimes, for example, at our centers, the surgeons will operate as long as there is at least 5 millimeter distance. So there is some flexibility about it, but it's so always include the distance between the tumor and internal cervical os. Another measurement that is important to include in this patient subgroup is the length of the cervix. Ideally, the cervical length should be 2.5 centimeters or more. However, these patients may have shortened cervix because of the repeat conization procedures, and the shortened cervix can result in premature labor and the loss of pregnancy. So if, for example, the cervical length is shortened to 2 centimeters or less, then the surgeons would not want to perform any more conizations because of this concern. And they may proceed with actually resecting the cervix and putting a cerclage at the end of the procedure to avoid premature delivery. I hope that answers this question. Thank you.
Excellent. Thank you. So looks like there are no more questions. Thanks everyone for joining again. Stephanie, Yulia, thank you so much. And it's a pleasure to always collaborate with you. And all right, everyone, have a great rest of the day, rest of your evening.
Thank you so much.
Bye.
Thank you.